A very good morning to all of you and greetings from Sydney in Australia. I'm sorry I'm not with you, but I'll be with you in spirit. I hope these slides are compliant, and I've been asked to talk about WHO or the WHO fungal pathogens priority list with a focus on research and why we have such a list. These are my disclosures, a couple of untied educational grants, antifungal advisory boards, and speakers' fees. So what I thought I'll do today is to present some of the key findings from the WHO fungal pathogens priority lists, which were developed using predefined criteria. And these are based on how lethal they are, how much care took place in hospital as opposed to outpatients, what are the complications and sequelae of infection, what about the resistance patterns, which is a key determining criteria, risks, preventability, and then finally annual incidence and global distribution, not necessarily in that order of importance. And I thought I would finish off by giving a broad perspective, which is largely my own, but also from clinical colleagues elsewhere, and focus on mold pathogens. Otherwise, we might be here all day talking about yeast as well. And the focus will be on the clinical needs and research. So what has prompted the WHO priority list? It's really about emerging AMR. Professor Chakrabarty's already given us a very nice overview of Candida auris. So I'll not say many things except to say that it's a highly important pathogen. And the key question is, where did it come from and what will it do in the future? We've also had a Cook's tour about azole-resistant Aspergillus fumigatus, which has emerged over the last decade and which has been associated with worse clinical outcomes. And this is an important pathogen because resistance is driven perhaps by environmental and agricultural factors, such as the use of azoles in soils. And the rates of azole-resistant A. fumigatus seem to be very high, particularly in areas of China and Southeast Asia, up to 90% in some of the studies I've read. That's incredibly high. So WHO has responded then by commissioning a group of clinicians and scientists and economics to form a FFPL to direct, firstly, R&D efforts towards pathogens by identifying where the gaps in knowledge are. If we don't identify them, we will not know. And then to define priorities to align with investments, both from industry and government, and also, clinically funded projects, and to align them with unmet needs. A third response is to enable international coordination or cooperation or networking to innovate new and to optimize existing therapeutics and diagnostics, everything that Professor Chakrabarty has touched upon. And finally, to facilitate regular review of antifungal development pipeline for trends and gaps, because if we don't review these, we won't know where the gaps are. So this is the process, and this is a slide of Dr. Justin Beardsley with thanks. The ranking process identified 19 pathogens to be prioritized. And looking quickly through the list, you might find that your favorite pathogen is not among the lists. So not all the endemics are on the list, and not all the molds are on the list, and certainly not all the yeasts are on the list. But as one WHO representative explained to me, we can't be prioritizing every single pathogen, and it is what it is for the time being that we focus on 19 pathogens. The assessment criteria I've talked about, so mortality, inpatient care, complications, drug resistance, preventability, incidence, access to diagnosis, access to treatment options, and what is the global distribution of cases, and what might be extended in the change in incidence or prevalence over the next 10 years. The ranking process was relatively complicated or relatively simple, depending how you look at it. But we've got this list of pathogens, and we've got these pre-specified levels for all criteria. So a systematic review was commissioned and blinded allocations were effected to the people reviewing particular topics. Expert opinion was sought where needed. And after the systematic review, someone had to determine the importance of the criteria. And this was made by the DCE, or discrete choice experiment cohort of mycology experts, which were drawn from the international community to inform the WHO FFPL of the multi-criteria decision analysis and to rank each pathogen according to these criteria. Each rank was then multiplied by the importance of the weight from the DCE. And I have a diagram in my next slide which might explain this better. Public health ranking was important, so each pathogen also received this, and the experts were asked to rank the R&D need with the public health importance need, with the base ranking, which is how important it is, how common it is, whether there's drug resistance or not. So I'm going to show you this diagram now, which is relatively complicated, but I hope explains the process that the invited panel was asked to go to. So let's take, this is Scedosporium. This is one of my favorite pathogens. On a base R&D rank, it's important because although it's not common, it has high mortality, it's difficult to diagnose, and it's often impossible to treat at times. But if you look at the public health ranking, it received a bottom ranking of 19. And therefore, when we came to the final ranking, it received only a ranking of 12. Okay, let's park that thought. So number 2, this is mycetoma. Base rank, also number 2, public health ranking, did a little bit better than Scedosporium, and therefore it finally received a ranking of 7. Let's move to Candida auris, which is dark purple. So the dark purple starts at 8. We know a lot about Candida auris. It's relatively well characterized. We know it's got infection control challenges, and it might be drug resistant. Where it came up really high, it's when it, public health ranking, you can see it's number 1, and therefore its final ranking was 3. This was trumped by Cryptococcus neoformans, which is the light purple one, which finally received a ranking of 1, had a public health ranking of 3, but in terms of what we know about it, how important it is, and what about its drug resistance, it only started off with a ranking of 10. So you can see that it depends on where you are, and the combined rank then came up with the top 3, which are C. neoformans, Candida auris, and Aspergillus fumigatus. So there we have it. Public health importance was a strong determinant of priority, and most respondents favored public health importance over the unmet R&D needs. Antifungal resistance was also a top priority, although not as important as the public health importance. Disease burden related criteria also ranked highly. The systematic reviews were done, and a global view was entertained, as well as an endemic view. And the final outcome, here we have it, the critical group, Neoformans, auris, and fumigatus. And this is fumigatus sensu stricto. We're not talking about the cryptic species, rightly or wrongly, but we can't sort of focus on everything at the same time. And Candida albicans also sneaked into the critical group. So the high priority group were things like glabrata, histoplasma, eumycetoma causative agents, the mucorales, and various other Candida species. And to my slight disappointment, the medium group incorporated Scedosporium elementispora. I thought they would have made into the high group, but they didn't. And here we have it. And this is something that we have taken on board. And I look forward to all the 14 systematic reviews that are about to be submitted to medical mycology and hopefully published soon after review. So I just thought I'd give you some thoughts about the moles, and here we have Aspergillus. So this is the third most critical organism. And human infection is well known, and there are at least 14 sections of Aspergillus that can infect humans. Let's focus on Fumigati because this is the one we know a lot about. And we know that A. fumigatus belongs to the section Fumigati. This is the species complex. And of the species complex, the one that we worry most about is A. fumigatus sensu stricto, because resistance has been identified in this species. And we can separate it from other members of the A. fumigatus complex by its ability to grow at 50 degrees C. There are, of course, other pathogenic species, a whole myriad of them within the species complex. We have the sibling species or cryptic species listed here, and they're important because they're more drug resistant than sensu stricto. Within the section Fumigati, we also has a viridianutans species complex, and with the species identified here, sensu stricto itself, Udagawe, and Felis, and they all can cause human infection as well as veterinary infection. I was speaking to Professor Houbraken about the taxonomy of Aspergillus because I was given cause to reflect more on this, and he indicated that the term species complex was about to become obsolete. This is after we have made inroads to change our naming, our nomenclature, our reporting, and instead of the species complex, it will be substituted by the name series because species complex does not have formal acknowledgement of status in the taxonomic world of fungi. So watch the space, it's about to become more complicated. All right. Now, what did the WHO find in invasive aspergillosis? It found that it was highly relevant. It was a One Health pathogen because it not only affected humans and animals, but it was found in the environment. There were 49 articles that were reviewed. So after all this, it was only 49 articles that provided the data that the WHO needed. They looked at death, and death was described at 30 days, 42 days, because this is what trials use, 100 days maybe, and some at 12 weeks. They looked at azole resistance and new risk groups, including those in COVID patients, so COVID-associated pulmonary aspergillosis, and compared it with non-COVID patients. Length of hospital stay, there was a dearth of data on this. There were only 2 studies. And obviously more work needs to be done here. And there was no data on IA complications or sequelae, surprisingly. Azole susceptibility rates varied greatly with the study and with geography. There was cross-resistance and there was increased rate within the time frame of review in one study. But we don't really know whether this increase is real or just observed or biased by the studies themselves. We've talked about the new risks. Dr. Chakrabarty has touched on this and about the annual incidence. And this was difficult to compare because of the variant denominators. And if you look at kappa alone in COVID patients, you find that the incidence or the frequency varies between 5 to 35%, wide variation. And aspergillosis is a well-known disease because it's seen in every area of the world. So just looking at the azole resistance, I had cause to review this for another reason. And in fact, it didn't look as bad as I thought. Even in Europe, in the latest studies, up to 2020, you find that the prevalence ranges from 3.3% in Turkey to 9.2% in the Netherlands. So it isn't as high as we thought it might be. Obviously, it will vary between whether it's a single study center or a multi-center study and how many isolates you study. But the references are all that, and you can read about those. In America, there was one study published in 2022, only 3.5% prevalence. Closer to home, here we have China, single study, 2 hospital study, 4.3%. In Taiwan, 1.8%. In Australia, and I guess we've been lucky, at a frequency of 2.6%. Nothing in the environment, and only 3 out of 117 clinical isolates. But this was done in a single jurisdiction. And I guess, what can I say? We've been a bit slack in not taking this further and in initiating a more recent study. We've talked about the One Health aspects, and the highest prevalence of azole resistance have been in countries using azoles in agriculture. But what we don't know is whether every use of the pesticide is equally harmful, about azoles and others. What do we do about the tulips and azoles if we were to stop azoles? Because we like to see this sort of thing when we visit Amsterdam, and not this sort of thing where there are no tulips to see. And what about the newer iflufenoquin, which is a cousin of olorifim, which is a dihydroorotate dehydrogenase inhibitor? Should we be more proactive as a mycological community in restricting its use, dare I say, or functioning in an advisory capacity? And certainly One Health collaboration is needed. So what are some of the clinical and research needs? The mortality measure. The WHO reviewed this and found substantial variation in time of mortality with the time points that were used, the patient populations, and uncertainty of trends over time. In RCTs, they use a 6-week mark and a 12-week mark, but perhaps better standardization is required. And very few studies, only 2 identified by the WHO, have measured attributable mortality. We should be doing this, but how to do this, how to define this, it's a bit of a challenge. Excess costs due to IA, again, a dearth of studies, and the longer term outcomes. Perhaps patients die too quickly, and it's a sad, but it's a realistic fact. But we need to look at those who survive and find out what the complications are and how to minimize the morbidity of these patients. With regards to resistance testing, we certainly need more studies outside of the Europe and USA, and to identify barriers and a link to outcomes as to why, the Asia Pacific region, including Australia, hasn't matched the studies that are coming out of Europe and the USA. New risks. We've talked a little about this, so I won't say very much. But I guess we have prophylaxis and treatment guidelines. The ECMM have guidelines, IDSA have guidelines, and the Asia Pacific has guidelines. But we don't know how to prophylax and treat CNS aspergillosis, bone and joint infection, and to recommend guidelines for patient groups outside of hematology and oncology, including solid organ transplants, including an ICU, including COVID patients. Do we prophylax these patients or not? Good questions. And what do we do about breakthrough disease versus primary disease? So these are some of the unmet clinical and research needs. There are more. We need oral treatments that are fungicidal. Right now we have olorifim, but it hasn't received FDA approval as yet, and we're still awaiting the results of the expanded 200 patient study. This is a phase 2B study, so we'll never be an RCT of rare mold infections and even of azole resistant aspergillosis. It's only an open label study. What is the best time to assess treatment response? Touched upon this, but should we be looking at shortening the time to treatment response? And what do we mean by response versus stable disease? Because at the moment, stable disease is classified as failure, and this probably biases your outcomes when you're looking at a new drug. Does one size fit all? And can we reapply response definitions of hem-onc patients to all host groups? And I don't think we know the answers just yet, but we should be challenged by trying to answer them. Other molds have similar needs to aspergillosis, but their burden is less, and therefore, the burden is less and therefore the data are fewer. And we've touched upon some of the rare molds such as the mucorales and Fusarium, Scedosporium, Lamentasporium. They have similar needs, but because the burden is less, it's difficult to mount a case for priorities and for investment to be the same in the same bucket as say for invasive aspergillosis. Nonetheless, we need to move beyond the classic or what we know. So we know a lot about mucorales in diabetic patients and also in hem-onc patients, but we know less about mucorales and certainly other molds in burn and trauma patients, maybe in cystic fibrosis patients, in lung transplant patients, and particularly for cystic fibrosis patients. What do you do when you see these infections? They will all come to lung transplant, so they all come to haunt us if we don't have protocols to optimize infection control and preventative measures before they come to lung transplants. In mucormycosis, there are additional needs. Some of these are hypothetical, but these were discussed at a recent MSG meeting. There are no randomized controlled clinical trials. Will we be ever able to do this outside of India? It might be possible in India. It might be possible with ROCM. Currently, amphotericin B formulations are used with step down to savuconazole or posaconazole. The optimal timing of step down is uncertain. Do we do this early? Do we do this late? And how early is too early? Look at other risk groups outside of hem-onc, outside of diabetes maybe, and maybe stratify trials by site of infection, not just in rhinocerebral mucormycosis. We need more case control prospective studies and more studies on combination therapy, because this is typically given very, very late in the game, and perhaps it should be given earlier. Other common modes with likelihood of RCTs are even smaller for non-mucorales mold pathogens, and we're restricted to open label studies and salvage therapy trials. The timing of enrollment is problematic because if you look at salvage therapy trials, patients need to fail before being able to enroll and to have a better or promising drug to offer. What's the purpose of the trial? If we enroll patients too late and when they are already failed, they will likely do worse than you might want them to. And it might be that we'll have to look at adaptive trial designs with its pros and cons. So you have a trial, but you change the design of the trial midway to fit the purpose of the trial. So I think I've asked more questions than answered any questions, but in terms of the WHO and the community, we need to focus on the unmet needs, so surveillance and burden, as Professor Chakrabarty has outlined. We should think about how we do clinical trials. We should look at populations that we know less about. We should look at sites of infection that we know less about. We should focus a little bit more on children and breakthrough infections. And finally, I'm sure it's the remit of the AFWG and certainly other professional society to promote discussions about these unmet needs and to promote discussions about laboratory capacity. Perhaps the response definition for mold infections need to be more realistic and to achieve endpoints based on specific pathologies and specific host groups rather than a one-cap-fits-all bucket. So thank you very much. And for those that think molecular biology can replace culture-based diagnostics, I don't know, have you seen anything more beautiful than this? You won't have the opportunity to grow fungi if we all relate to molecular-based diagnostics, which I know are very important, but culture still has a role. So happy to take any questions.